So yeah, hi everyone. I'm Maya. I'm one of the peds hospitalists that co-leads Peds Echo Hawaii. We are just coming up on our 5th anniversary. Actually, we started in May of 2019. So we're so happy to have each and every one of you here and to keep on sharing really important topics and knowledge that helps you all in your professional capacities. I will say for autism, it's such a timely and important topic, and I think there's not a single one of us who isn't touched both professionally and personally at this point with the, sort of exponentially rising prevalence of autism in our society. And the fact that these children still face so many barriers and challenges that we really are so happy to have this opportunity to learn a little bit more about how to diagnose autism accurately and to understand that there are an awful lot of other developmental and challenges that folks may face that don't fall squarely within the sort of definition of autism. So the way it works, Dr. Samelson and Dr. Sneed, is that we really try to let you folks kind of go through your presentation, and save some time for questions at the end. But we do love for it to be interactive whenever possible. And so I'll be kind of keeping an eye on the chat box. If there are questions or like clarifications that are kind of important to address right in the moment, I may go ahead and interrupt you. That way you don't have to look at the chat box while you're trying to focus on your slides, and I'll just say, excuse me, and I want to ask this question on behalf of one of our participants. So if that's okay with you, we'll do it that way, which is our usual MO, and then hopefully have some time at the end for questions. And also just reminding everyone who's here, this is a safe and confidential space to talk about your own patient experiences. So if you are having challenges with any of your patients, or if you wanted to share a story that you think would be educational, we always welcome you to do that as well. So without any further ado, I'm going to pass it over to our presenters, and we'll go ahead and hear what they have to share with us today. Thank you.
Thank you so much. We're very excited to be here today, and we're pretty flexible. Lindsey, Sneed, and I. So
yeah.
I'm Doreen Samelson. Go on to the next slide, I think, Lindsey. And I am the Chief Clinical Officer for Catalyte. We're a large nonprofit. I'll say some little bit about Catalyte in a minute. Lindsey Sneed, Dr. Sneed is a psychologist, as am I. And she is also a doctoral level behavior analyst, and she's the VP for Clinical Excellence for the Catalyte Research Institute. And we don't have any financial relationships or anything to disclose. So a little bit about Catalyte. We're a nonprofit, as I said. Our mission is to create a more equitable world so people with disabilities, particularly developmental disabilities, including autism, can choose their own path. We served about 1,400 families every day. We served a total of almost 17,000, going on 20,000 families, both in Hawaii and in California. And all of these families have a family member with an intellectual developmental disability and/or autism. So learning objectives today, you've already seen them, so I will not spend too much time on them. We're going to talk about the ASD diagnosis. I'm going to talk a little bit about the history and the diagnosis. And one of the things I think about when I think about autism is really autism is a construct. And within that construct, there are a lot of other diagnoses that can either fall under that umbrella, that construct umbrella, or not. We're going to talk about the increasing prevalence, why we don't have the definitive answers of why the prevalence is increasing, but we have some ideas. Talk about the overlap with other conditions and describe what factors, kind of baseline factors, really influence outcome and treatment for children diagnosed with ASD or autism spectrum disorder. So here's our little review of autism spectrum disorder. I just want to say I met my first autistic child in 1982, which was a while ago. And the prevalence at that time was still that same prevalence it was in the 60s, actually, was one in about 2,500. First appeared in the DSM, which is our diagnostic manual for mental health disorders, in 1980. It wasn't until 1991 that children with autism really qualified for educational services. DSM-4, which came before our most recent DSM-5, obviously, expanded the criteria and added other diagnoses, which we'll talk about in a moment, including Asperger's. We no longer have Asperger's, but it was added then. And then in 2013, DSM-5 expanded the criteria again and created the spectrum. So that's when we got the spectrum. So now, and when we talk about the prevalence, one of the things that is really clear to me is we're talking about the prevalence of the diagnosis. And since it is such a heterogeneous diagnosis, it's a little bit sticky, but we're just counting the number of kids that have been diagnosed, basically. So let's look a little bit more to understand kind of where this construct came from. So Leo Kanner was not the first, but he was one of the early physicians that identified a group of children that he felt had this thing which he called early infantile autism. It was considered rare at that time. Even when I met that first child in 1982, it was considered rare. It was a two-factor diagnosis, problems with social interactions and connectiveness. From the beginning of life, we still have a version of that. A resistance to change and insistence on sameness, some stereotyped behaviors, such as rocking, hand flapping. So it was two factors, and he had 7 criteria. And there he is, Leo Kanner there. Then at DSM-3, we have actually now the diagnosis in the DSM. It is now among a class of conditions called pervasive developmental disorders, or PDDs. There's a triad. We have 3 factors now. So you can see the factors there. We have impairments in reciprocal social interactions, impairments in communication, and restricted interests and resistance to change. Additional diagnostic terms were included for the cases that did not quite meet criteria. They were sort of residual cases, I guess people were thinking of them that way, or cases that no longer met the criteria. Then in DSM-3-TR, in our field, we keep changing our criteria for different diagnoses. So they kept the triad, they kept those 3 factors. They moved to diagnostic autistic disorder and required at least 8 positive criteria, 2 from the social domain and 1 each from the other 2 domains or factors. So you can see, it changed it up a little bit. Then the next change is actually DSM-4, and we have a big change because we added more diagnostic options with different criteria. So this is a DSM-4 and even 3, but certainly DSM-4 was a diagnostic manual that I worked under for many years in my career. And so with diagnostic disorder and Asperger's disorder. And Asperger's disorder, those are probably the 2 most commonly diagnosed, along with pervasive developmental disorder, NOS. In mental health, when we're not sure about something, we always put NOS or not otherwise specified after everything. That's been kind of a thing that we do. Not particularly helpful, by the way, but you see that. So autistic disorder and Asperger's disorder were probably the 2 big ones. Asperger's disorder was named after Dr. Asperger's. He actually was probably not a very nice guy. He was a pediatrician in Germany and not Nazi Germany, and he is responsible probably for the death of many, many children with really severe developmental disabilities, severe and profound intellectual disabilities. So, and they named the disorder after him, but he probably wasn't really a very good guy. And then the autistic disorder had similar factors to DSM-3, so they kept those factors, but they then added these other disorders. So you're probably getting the idea now that, things are kind of shifting a lot when we think about the construct of autism as a whole. And then in 2013, entered the spectrum, back to 2 factors. Now, the interesting thing about the spectrum is that the idea was from the DSM committee, the DSM-5 committee, was that it was supposed to improve the diagnostic accuracy of autism. That was actually one of the goals. And there were a number of articles in 2013 or 2012 as a criteria coming out that really were suggesting that the prevalence was going to go down, and actually the opposite happened. The prevalence just, went up and kind of really exploded. So here we have the two factors, and I'm going to turn this over to Dr. Sneed. Lindsey does a lot of diagnostics. She's a very experienced diagnostician, and I will turn it over for, this is the criteria we are now currently under. So if you have a child who has been diagnosed with ASD, it is with this criteria. Lindsey?
Yeah. So keeping in mind everything Dr. Samelson already said, we moved to this two-factor model. And you can see the two factors here. And it really does feel, if you were to look at this and you're to read Dr. Leo Kanner's seminal article, which qualitatively described 11 patients who he diagnosed with autism, you're going to feel those similarities between what we're going to review right now and that article. I highly suggest reading it if you're interested in reading historical data. So we have the two factors. There's 3 items under criteria A and then 4 items under criteria B. So under criteria A, in order for an individual to receive an ASD diagnosis, they have to have marked impairment in each of these areas. So there needs to be marked impairment in social emotional reciprocity. There needs to be marked impairment in nonverbal social communication and marked impairment in reciprocal relationships. So all 3 of those things have to be present. And then in criteria B, they only have to meet 2 of the 4 items. So there has to be at least 2 of those items there. So it could be repetitive speech, movement, or use of objects. So this is what we might liken to hand flapping, observing objects closely or bringing them close up to your eye. It could be adherence to routines and rituals, needing things to be followed in the same way each time. And then restricted and intense interest, like I have never met an autistic person who doesn't have a special interest, and it's not many interests. It's usually one interest, one thing that is very, very important to them. And even if they have an intellectual impairment, I am still finding that these patients have something that they're very interested in. I have one individual who is 9, who I've been working with for quite some time. Level 2 ASD, which we'll get into in a second what that means, but also an intellectual disability. But he is like obsessed with mall escalators, and he knows where all the mall escalators are in our area and the best ones. And you can talk with him about these for hours and he would be so happy. And then I have, excuse me, other people on the spectrum whose special interest might be maybe not so niche, but could be something like trains or books or movies. The Marvel Cinematic Universe are just some areas. So there could, like, that restricted intense interest may or may not be present. And then you have unusual sensory interest or reaction. So this could be hyper or hypo reactivity to the sensory aspect of the environment. So you could have some people with autism who are sensory seeking, who do engage in a lot of behaviors for sensory input. And then we also have autistic individuals who are hypersensitive and are very averse to sensory input. So within this, we are able to capture a lot of diagnoses with ASD, but whether or not I can't say if it's good or bad, it is what is happening. But what makes it really, really interesting, particularly when thinking for Dr. Samelson and my work, is identifying when they come in for behavioral health treatment, when they get a referral, when we find out that they have autism, it actually doesn't mean a whole lot to us anymore because we don't know exactly how they're going to present. And the reasons on the right are part of the complication. So in addition to having these criteria, and they have to meet early, like it has to be something that is present in early childhood, the language level might be very different. we have individuals on the spectrum who have very fluent language. It could be fluent but rote, meaning that they might use scripting to communicate, scripting things that they've heard before to facilitate communication. They may have minimal words or be completely nonverbal or not have access to language in the way that like I'm using my language right now. So we have these language differences. We have intellectual functioning differences. I'm going to tell this story kind of quick, but I think it's really important to conceptualize what we are finding is last year, over the course of 1 week, I saw one individual, young child, who I did provide a diagnosis of autism spectrum disorder level 3, and an intellectual disability diagnosis. Very, very impacted young child. And when I went through the criteria with the caregivers, explained what was happening, they were very surprised to hear the diagnosis, not because they didn't think autism was present, but because they had no idea how severe it was. And their questions to me were, will he go to college? Will he have a relationship? And I don't have a crystal ball. I cannot see what's going to happen into the future. But your child is pretty impacted by their diagnosis. And, he's probably going to need like support for the rest of his life. A week later, I am seeing a 11-year-old with coming in for an ASD evaluation. He does have autism spectrum disorder. But as I'm interacting with this guy, I'm like, man, this guy seems really, really intelligent. Like above, I have a child who's approximately his age, and it was like above and beyond what I experienced. So I did intellectual testing with him, and his IQ was in the 0.01 percentile, well above the 140s for intellectual functioning. But he also got an autism spectrum disorder diagnosis with no intellectual disability. And the parents asked me how intensive of treatment he needed. And I'm like, well, he doesn't really need like super intensive treatment. Maybe like you might want to support him with some social stuff. But I give those two scenarios because that is what we see on a regular basis. We get 10 children with autism and their needs are so varied. So then we have co-occurring symptoms. We have very, very high co-occurring symptoms with ADHD. As we get into youth and adulthood, we see high co-occurrence of anxiety and depressive disorder. And there's been recent studies demonstrating the high rate of suicidal ideation amongst this population as well. And then for individuals with ASD who are more impacted by their diagnosis, we do commonly see medical conditions, epilepsy, gastrointestinal difficulties, things like that. So we're seeing more severe cases, but they have the same diagnosis. So kind of what does it mean? So when we provide a diagnosis right now, we qualitatively describe it in the ways that you're seeing on the screen. So we qualitatively describe criteria A, the social aspect, and then we qualitatively describe criteria B, the restrictive and repetitive behavior aspect. Essentially, level 1, what it sums up to being is this individual might require some support. Level 2 is they're requiring substantial support, and level 3 is requiring very substantial support. And again, we rate each of those differently. These levels are also a construct. They were also made up, and we might use them to help individuals understand and guide to the level of how impacted usually their child is by their autism diagnosis. But Doreen and I were literally just talking today about how, for me, in my work, I almost wish that Asperger's syndrome was never gotten rid of, because I actually think it helps explain some people's experiences a little bit better than autism does presently. And I'm going to let Doreen talk about this.
Yeah, thank you. Thank you. So thank you, Lindsey. So one of the things I want to point out about the two kids that Lindsey talked about, the child with the youth with a very, very high IQ, by the way, his special interest was a particular math
Yes.
Well, to tell you the truth, I didn't understand any of it, so it was way above my head. That is not, in my opinion, probably something that's going to interfere with his functioning. This is the kind of kid that will get perhaps a scholarship to an school like we're here in California, Stanford or someplace, and be some kind of math genius. I thought the best intervention was probably the Stanford Math Camp for teenagers, which they hold every year for kids who have really high IQs and are really into math, versus a child who probably has an intellectual disability and autism, and their special interest is escalators, or a young, actually she was a youth that I met last week who had a special interest in a figure for Iron Man, an Iron Man figure, which she carried around with her. She has an intellectual disability as well. So the intellectual disability will, obviously affects the interest. Okay, so we are seeing a class of autism that some people are calling syndromic autism. This is also a little bit controversial, but what we are seeing more and more is that children with known what I would call major genetic disorders are diagnosed also with autism. Fragile X is probably the most common one. More than 50% of boys with Fragile X are also being diagnosed with autism spectrum disorder. Now, do they have autism or do they have Fragile X? Fragile X has its own, set of symptoms, which can include things that really do overlap with autism. I have a particular feeling about these disorders. I think Fragile X is Fragile X, not autism, but most of the kids will be diagnosed with autism who have this disorder. And there is a regional effect here where, depending on where they live, I would say if they're in California, any of these examples of genetic conditions, they will get an ASD diagnosis. Profound autism, you can look at this study, Hodgins et al. 2023, suggesting that perhaps in some time in the future, there will be a diagnostic label called profound autism. There is a group of parents who are actually pushing very hard for this. This is a group that the CDC is now tracking. This is new. They are saying that at least 27% of all the kids diagnosed with ASD now have qualify for this profound autism diagnosis, which again is not an official diagnosis yet, but it could be coming. IQ under 50, minimal language, and often we have dangerous behavior. Now, the thing about when you get into IQs that are pretty low, you get under 50, certainly when you get into the more profound level of intellectual functioning, you have a lot of behaviors that may look autistic. And you think about a child that has an intellectual disability and you ask what their social skills are like, probably their social skills are not that great. Are they missing social cues? They probably are missing social cues. If they haven't developed language because of the intellectual disability and they have minimal language, that is going to affect their functioning, of course. And again, they might look like they qualify for an autism spectrum disorder diagnosis. One of the tricky things is that for many of these kids, and we see a lot of these kids, a lot of the kids that Catalyte takes care of have autism with an intellectual disability or autism with another co-occurring condition that is significant. And when you think about disability and lifelong disability, it's often the intellectual disability that in fact is going to be really the difference between somebody living independently or semi-independently and somebody living in a group home. And so, that cognitive ability becomes really important. One of the books that I recommend, which is very interesting, that a historian wrote called Chasing the Intact Mind, gives some history of the idea of the people with intellectual disability and autism. And there are, unfortunately, some people that feel that this group of people actually have an intact mind, but it's hidden somehow by the autism. And so we are missing intellectual disability in some of these children, which is actually a problem and becomes more disabling for them. There is something called an autistic social identity. If you go on TikTok, you can be diagnosed with autism, apparently. I have not tried to do that, but that's what I hear. There was actually a study published last year about that. there is a lot of information on TikTok about autism, which is mostly not accurate. But there are a group of people that identify as autistic and have not been officially diagnosed. And then there are people who identify as autistic adults, advocates who have been officially diagnosed. And there's a whole issue around, could there be a social identity of autism? So you see, when I say heterogeneous group, it's an extremely heterogeneous group. So going on to the prevalence now, thank you, Lindsey. It's the fastest growing, autism is the fastest growing developmental disability in the United States, according to the CDC. We are at 1 in 22 4-year-olds and 1 in 22 8-year-olds in California have a diagnosis of autism spectrum disorder. Nationally, the estimate is 1 in 36. Now, I have talked to some of the people involved with the calculations of the prevalence, and there is a whole way that they do it. And the way that they have counted diagnoses has changed over time, so it gets a little bit tricky. California is leading the way. I don't really think that 1 in 22 4-year-olds in California have autism. I think 1 in 22 4-year-olds may have a delay of some kind, or there might be something going on. And of course, some of them do have autism, but autism has become the go-to diagnosis. And I think that does carry its own problems. And if we go to the next slide, I think we will get into some of the more particulars of the diagnoses and what we do in terms of assessment technologies. And I will turn it back to our diagnostic expert, Dr. Sneed.
Could we take a quick moment here to ask a question that's in the chat?
Yes.
Monica asks about the syndromic autism diagnoses in particular. Are they considered co-occurring, or is being syndromic, in quotes, meaning on the spectrum?
Syndromic meaning on the spectrum with co-occurring genetic disorder is how a lot of people would say it. I think it's depends on who you talk to, however. There are people who feel that Fragile X is somehow causing autism, and there are people who are investigating and researching Fragile X to see if there's some thing about Fragile X that can tell us more about autism, for example. And there are others, and I would be in this camp, who would say, you know, most boys with Fragile X also have intellectual disability, and they have certain behaviors that may look like autism. But it really depends on who you talk to. It's complicated. I will say this, if you have a child with Fragile X and they need services, the sad thing is the quickest way to get them behavioral health services is with a diagnosis of autism spectrum disorder. And it shouldn't be like that, because I think that children with Fragile X can benefit from behavioral health interventions, but the autism is the one that's tied often to that benefit.
Yeah, Monica said she's seen the same thing, that it's that it helps to get services, and thank you for that.
That's right.
And I'll just add, as a hospital pediatrician, you know, who sees a lot of children with complex medical and neurodevelopmental challenges, and, you know, in my day-to-day life, I think, you know, the way genetics is growing by absolute leaps and bounds, and we can send a whole exome on whoever we please at this point. And then there are panels for, you know, an epilepsy panel, and you know, there's like numerous different panels. So I think that probably the answers to this question are going to change over time as we gain a greater understanding of both single genes and interactions among genes, and you know, the way that they affect behavior, which is such a fascinating and rapidly growing sort of area of science.
No, I absolutely agree with you. I mean, we see all kinds of deletions and things that we just didn't know about before. It wasn't that we didn't see them, we just didn't know, right? And it's very complicated. Well over 100 genes, single genes, not major genetic disorders, have been associated with autism, well over 100. And then all of these major genetic disorders. So it's extremely complicated. Yeah.
And there certainly are kids with Prader-Willi who don't have autism.
Certainly, yes, yes.
You know, so back to that question, Monica, of, you know, syndromic, I think maybe, at least from me listening to this and sort of adding my own experience, maybe the best way to think of it as like a Venn diagram, where there's overlap, but there are also areas there where the circles are not meeting.
Yeah, I agree. That's a good way to think about it. Thank you.
All right, thanks. All right, why don't we go ahead, Dr. Sneed? Thanks.
Yeah, and I think like the overlap is actually a good segue in to the diagnostic procedures, because it within this, when you're doing a diagnostic evaluation, you're constantly thinking about the overlap. Like what else is explaining what is happening right now? So when we're doing a diagnostic for autism spectrum disorder specifically, the first thing is oftentimes we do see young children, but we're getting youth and adults. And it's sorry, I have my notifications off, but they keep on popping up. I apologize for that. And now that completely made me lose my train of thought.
Youth and adults.
Thank you. Okay. Youth and adults, and we have to see the symptoms in early childhood. So it can't be something that all of a sudden started recently. It can't even be something that started in middle or late childhood. It needs to have started in early childhood. So the symptoms have to be present at that time. So we need a pretty good developmental history, and that demonstrates that those symptoms, even if they're a 30-year-old, that demonstrates those symptoms were also present. They may look different when they were 3, 4, 5 years old. So we're going to look at language. That's another important piece here. Language is going to tell us a lot about the individual. One, like with language, if they have a lot of language, if they have fluent language, we're already going to start ruling out some things. If they have very minimal or rote language, that's going to help us start ruling in some things. So language, understanding where language is at is very important. Doing intelligence testing is very, very important, because where you can, for over the age of 6, you can do like a formal Wechsler intelligence scale, where we can understand like where is this person at in their cognitive ability. A behavioral observation is included in this as well. So not only are we seeing this reported by caregivers or the individual or through multiple questionnaires, but as a clinician, I'm observing these things too. What is happening? How is this person interacting with me or not interacting with me? And then there needs to be marked challenges in that criteria A that we were talking about previously. And they have to be causing marked impairment in the person's life and be best explained by autism spectrum disorder. And I'm going to get more into that in a second. And then the presence of restrictive and repetitive behaviors also has to be marked, causing marked impairment in the person's life. And again, not better explained by another diagnosis. So in addition to these things that need to be present, the criteria A and criteria B needs to be present in early childhood and shouldn't be better explained by another diagnosis, including intellectual disability. This is why what Dr. Samelson was talking about is so, so important, because we do commonly see repetitive types of behavior across individuals with intellectual disability. There is going to be social difficulty. So it's so important to continually be parsing out what is ASD and what is not ASD. And you're kind of like have all this information in your mind at once as you're trying to figure out exactly what may or may not be happening. And sometimes, especially with young children, and ASD is, it's not present. They might in early life get a global developmental delay diagnosis. Oftentimes, if they get a global developmental delay diagnosis, GDD, they should be assessed later on in life to see like what level their if they have intellectual disability still, or if there is intellectual disability present, sorry. And to what extent is the intellectual disability present? And then the nice thing is this became very much true during the pandemic. And thankfully, there was already research burgeoning in this area, but telediagnostics for ASD. While we don't seem to be missing anybody in California, there are parts of the United States that are very rural, and it is hard for individuals to come into a clinic or see a clinician to get a diagnosis. So specifically, I'm going to speak to Vanderbilt University in Tennessee. They've done a lot of work because they have a lot of rural communities in Tennessee. And so they created a telediagnostic tool called the TAP. And the TAP was shown to produce good sensitivity and specificity for autism diagnosis before the pandemic even started. So, and there was a study done in 2018 looking at the TAP. And then when the pandemic started, Catalyte actually adopted the TAP as our telediagnostic tool for children under the age of 4. And the really amazing thing about the TAP is, as a clinician, I feel very confident in my implementation of the TAP, and being able to see a patient in their most natural environment, their home, is actually very, very beneficial diagnostically, because we're able to see what they are like in their most comfortable environment. Because ASD isn't like in one area, not in another area. It's in all areas. So there's going to be social difficulty at home. There's going to be social difficulty in a clinic. So that's one of the nice things about having the telediagnostic ability. Telediagnostic is still completed by a qualified licensed psychologist under our work. I know developmental pediatricians and pediatricians also do diagnostics. And then the other really wonderful thing about the telediagnostic option is right from the beginning, caregivers are very heavily involved in the diagnostic process. And so it's giving that idea from the start that parents play an important role in who their child is and who their child is becoming. But with that, you know, speaking about the overlapping pieces of the Venn diagram, like there's got to be things that we're missing. There are overlapping conditions, as we've been alluding to. And I'm going to let Dr. Samelson.
Yeah, I think I'm going to do a Venn diagram next time. I like that. So,
yeah.
So here's one of the things that we're really missing, and that's intellectual disability. Thurm et al. In 2019, this is actually under DSM-4, not DSM-5, found that as the diagnosis of autism was going up, the diagnosis of intellectual disability has been going down. This is actually probably not really logically possible. We're still seeing that under DSM-5. It makes it difficult. There is some preference, it appears, for autism over an intellectual disability diagnosis. Also, a lot of autism research excludes patients with ID, which is another big problem. And that was happening when Russell et al. Published their study in 2019. It is still going on now. And it is, I think, you know, problematic. Now that we have this big spectrum, we have this large group of people with ASD that's so heterogeneous, it's actually difficult for researchers. So they tend to, you know, take part of the spectrum. And I think it's just easier to do research with kids and youth and adults who do not have ID. And so we see this a lot. Dr. Thurm, Audrey Thurm's at NIH. She speaks about this a lot. She's actually very good. We had her speak at our conference recently, and she and I have real big concerns that we are missing intellectual disability in children. We are seeing an increase in youth and adults, families of youth and adults seeking assessment for intellectual disability. These are youth or young adults who were diagnosed with autism as young children. That diagnosis got them the services they needed in the schools. It may have got them ABA, you know, from their healthcare provider. But as they move into adulthood and they need adult services, they need to keep their waiver, they find that they need to have this additional diagnosis. These are mostly kids that probably everybody knew they had an ID diagnosis, but they were never officially diagnosed. They may have had a GDD diagnosis from way back when, before they were age 5 or 6. So this is a new phenomenon, and unfortunately we're seeing for adults and children, the services tied to different diagnoses, which doesn't make a lot of sense, but you know, that's where we are. So that's an issue that we're seeing. And if there was a question in the chat, I'm happy to take it. I do want to leave time for questions. Big overlap between ADHD and ASD. DSM-5 allows the diagnosis of both. Depending on the study you read, there's an overlap anywhere from 30 to 80% of children meet the criteria for both diagnoses. It does seem that the symptoms are more severe in children that have both diagnoses. This article, Hours et al. 2022, is a very interesting one. And because, you know, autism has with it problems with concentration and other kind of executive functioning problems that you see in ADHD. So parsing out which is what and can be very difficult. And one of the things that we do know is that if the child does have ADHD and autism, and you're not addressing the ADHD, any behavioral treatment for autism is likely not to be as successful. So if they do have both those diagnoses, it's important to look at both. And then going on to the next slide, of course, anxiety disorders. There's some new research looking at personality disorders, which usually we don't diagnose until older teens or adulthood, but overlap again. Going back to, you know, unfortunately, some of the subjective sort of quality of the way that we do our diagnosis. And I just want to say something about treatment, and then I think we can probably take some questions. I think this is getting to the end. ABA and related behavioral interventions are certainly an option. They are not the only option. And one of the myths about autism is that ABA is the only empirically based treatment for autism in children. It is not. And other interventions, including speech and language therapy, OT, I think we underutilize OT, are empirically validated. And for some kids, like that very genius youth that Dr. Sneed was talking about earlier, honestly, my thought about an intervention, if you want to call it intervention for him, was to go to the Stanford math camp with all the other teenagers who are really, really smart and want to talk about math all day. It turns out that parent-mediated intervention, parent-mediated behavioral intervention, including parent-mediated ABA, is as effective, if not more effective, than the paraprofessional delivery. But most children who are getting ABA in the United States, including Hawaii and California, are getting the paraprofessional delivery. They're not getting parent-mediated ABA. You can look at Sneed et al. 2023 to see a comparison of the two models of delivery, parent-mediated and paraprofessional-mediated. You will see that actually parents are quite good. We teach parents in parent-mediated intervention or parent-mediated ABA to change the way they parent. We don't pay them. They're not RBTs. We change them. We teach them to use behavioral principles, ABA interventions during their normal routine parenting. We don't ask them to sit down and spend 2 hours a day doing ABA. We would never do that. I don't think any parent would do that. I wouldn't have done that when I had young children. They change their parenting. We actually have we do a lot of parent-mediated treatment. We do a lot of paraprofessional mediated treatment as well, but we actually have higher satisfaction scores with our parent-mediated parents than the other parent group. Here's really two very important points that, again, myths about ABA or our population. Baseline cognitive abilities, again and again, show to be the outcome predictor. So kids who have higher baseline cognitive abilities do better in behavioral treatment like ABA. Does not mean that those kids who have lower cognitive abilities don't benefit, but they don't do nearly as well. And treatment hours is not a predictor of outcomes. The high hour ABA is not only unnecessary, but it can be actually very difficult for families, and actually most ABA providers have a hard time delivering those high hours. But the research over and over again, the recent research over and over again shows that hours does not predict outcomes, and you can get good ABA outcomes and progress in children with autism and intellectual disability, or autism without intellectual disability, with low hours, which is good news, I think, for everyone. And we can take questions on that if you have questions. Catalyte.org, we have a lot of information. We have our well-being scales and other scales, including parental. Is our parental stress score up on the website? They were redoing the
Almost.
website, so don't
I
know.
approved the copy today.
You approved it today. Okay, it's going to be there. These are free to download, free for you to use. They're short scales you can give to parents. And our family well-being scale, we've published on it. It's really good. Our practice guidelines are also available. We have a lot of stuff available. We're a nonprofit, and we just want to spread our research and spread the good news. So please check us out. And I think we should just go to questions, I think,
Yeah.
huh, Lindsey?
Uh-huh.
Yeah. So we have some time for questions.
Thank you so much. There are some questions in the chat from sort of just following up on the conversation we had about diagnosis and genetics. And Danielle says, our current way of doing things is to look at the phenotype and then get the genetic test to determine the genotype. I think in the future, we'll be looking at genotype and seeing that the phenotype varies more than we thought it did. And I think that's a really interesting observation.
I think so.
You know,
Yeah.
I'm excited to see how our practice will change,
Yeah.
not just in, developmental peds, but actually throughout all of medicine. Monica, you had asked about what if not identified until later childhood? I'm not exactly sure what the context was for that. Do you mind unmuting yourself and explaining what your question was? Monica? Yeah, there you are.
Hey there. Sorry, I had to try to unmute. Meaning I've seen kids get diagnosed at 8, at 10,
Sure.
and so and these are kids I know. So I'm like, I don't know if that's what it is. Like for me, I'd be like, I'd lean more toward ADHD, but I wasn't the assessor. So that's my
Right.
and I've even asked the parents. I'm like, are you sure? Did you want to ask more questions about that? So I don't know. I mean, if it's part of the, is it part of the criteria for the program, or is it the?
No, that's part of the
criteria?
criteria that it's in that it's like in the early stages of childhood that the symptoms are present. So when I assess an 8-year-old or a 10-year-old, those symptoms need to have been present when they were 3 or 4 years old.
And if not, how do you?
And it's hard to know sometimes, right? The parents may say something or you don't know, but you as a pediatrician aren't seeing it, and you knew them when they were 4 years old. That's kind of telling, I think.
And I wouldn't provide, like in that case, like one of my personal qualifiers in diagnosis is 100% confidence one way or the other. And because they aren't meeting that early childhood criteria, that would diminish my 100% confidence personal criteria, and I wouldn't provide an ESD diagnosis. I'd recommend a differential.
But then I have the parents also being like, oh no, they like it.
Right.
Now their kid's going to get services.
Yeah. So interestingly enough, when we get complaints now, this would never, I mean, if you told me this in 1982, that parents would be seeking a diagnosis of autism, I would have told you that's ridiculous. That will never happen. We have parents seeking diagnosis, and the grievances or the complaints we get are when we don't diagnose. We don't get complaints when we diagnose for the most part. Occasionally we do, but we mostly get complaints when we don't diagnose. It has become, and this happens in behavioral health, has become the popular diagnosis. It's also preferred, I think, even for psychologists. And here's a typical thing. A psychologist could be evaluating a child, could be an 8-year-old, and maybe the 8-year-old kind of has like a borderline IQ. Their IQ is like 72, 73. I've looked at some of these kids. And they're so, if your IQ is like 72, your social skills are a little, they're not that perfect, right? And you may miss things, and you may engage in some kind of behaviors. And it's hard to say to a parent, his IQ's on the low side, and, he's really going to struggle, and no, he's not going to go to medical school, or he's not going to, it's just not going to happen. And it's easier to say he's on the spectrum, particularly if the parent is seeking that diagnosis. And we have a lot of autism centers now, autistic diagnostic centers, and there has been some qualitative research where they're going in and they're interviewing the psychologists and the developmental pediatricians that work at these centers. And one of the things that comes out of that is this theme of the practitioner, the doctor saying, you know, they come to me and they're expecting a diagnosis of autism, and it's really hard when I say, I don't think it's autism.
Mm.
And so there's this expectation on everybody's part because it's a diagnostic center for autism. It's not a diagnostic center for IDD, right? For developmental disabilities. And I think that's a problem. But you know, Monica, what you're saying, we see a lot.
There are a few more questions in the chat.
Right.
Danielle asks, are there race ethnicity differences across any of the criteria in either A or B criteria? And I would add to that, you know, what if there are, given that race is not biologic, what might be the causes for that? Are they socioeconomic differences? Is it potentially epigenetics from racial trauma and other inherited traumas? Or what would you posit as a reason for that?
There's no difference in the criteria. The criteria is the criteria. There have been racial differences in the rates of diagnoses and the age of diagnoses.
Although I see how it was confusing. Danielle, feel free to unmute yourself and clarify if that wasn't the question.
I just didn't know if you thought of kids of different races or ethnicities differently, if there was a changing of how you would diagnose it. Sorry, I've got a terrible cold. So I think you answered my question there. You don't change your diagnostic criteria depending on race or ethnicity.
No.
You don't, but you should be taking race and culture into account for things
Yes.
like social skills, the way the child, you know, and also I want to talk about trauma, because if you have a child who's not making eye contact and they're not wanting to engage with the psychologist and talking to the psychologist and they're kind of putting their head down, you know, could that be that child is experienced some trauma, or could that be that child is just really very anxious and afraid of the psychologist or the developmental pediatrician? We should be taking all of those things into account. And I don't know that that's always the case. I think, you know, people like Lindsey, you know, try to do that. We need more psychologists of color who are trained to do diagnostics. I will say that. I think, you know, the overwhelming majority of psychologists doing this work and the overwhelming majority of clinicians providing treatment in this space are white. It's a problem, I think.
Yeah, thank you for that. The next question is about ABA. What would you consider short and what is long hours for ABA when you're talking about the relative sort of effectiveness of the short versus long?
Yeah, there's likely we can give a pretty precise number on that because there's been some pretty good studies. But what's typically recommended, actually, the Council of Autism Service Providers, which we as a provider, we do not follow after these particular guidelines. They're called CASP guidelines. They recommend 25 to 40 hours per week of ABA intervention. And they say that that's what everyone should be getting, particularly like early young children. However, recent research in the last 10 years has shown that many hours is actually not necessary. And we can see really significant progress around 10 hours per week. So studies have been showing like between 8 and 15 is kind of the range where we're seeing similar results in treatment outcome. There is a big randomized clinical trial done the study came out in 2021 by Sally Rogers and colleagues. And they did a multi-site, 6 sites?
Yeah, something like that, 5 sites, maybe.
Randomized clinical trial where the patients were put into 4 groups. So a naturalistic developmental behavior intervention, so an NDBI, or like AB, or your typical ABA treatment. And they were randomized further into either receiving 15 or 25 hours per week. And the results of their study demonstrated there was actually no difference in treatment outcome across all 4 groups. All 4 groups made significant progress. So because of that, I feel very confident in saying, as a clinician, no more than 15 hours per week is necessary for young children. And we see diminishing effects for children over the age of 7 when you get into hours. And a study was done in 2007 that also demonstrated that there was diminishing effects over 20 hours. So that's why like that 15 hours for young children seems 10 to 15 seems to be a good range.
You can look at our practice guidelines. We go through a lot of the research and the hours. There's a study that's coming out any day now. It'll be Anderson et al. 2024. And they didn't see any difference between, I think it was 6.5, 7 hours and 25
15,
hours.
25, yeah.
25 hours. And that was a randomly controlled study done with Vanderbilt and the May Institute. So more and more research is coming out showing there is no dosage effect. But Sharon has a hand up. I see that.
Well, you already started to answer my question, because my question was really about, the different ages as along that age span of like, is there different dosages for different age groups? But also as you're speaking, I'm also thinking about our kiddos in different settings that are receiving ABA. And I'm really thinking about school and then about home settings and then clinic settings, and kind of a comparison of that in the context also of the age of the kiddos.
Mm-hmm. There's less study on school ABA, interestingly enough. And when we looked at ours, at our guidelines and looked at all the research, we were looking at non-school ABA, if that's a term, but that school ABA that didn't occur in school, so it's a community, so either home or clinic or, and I think for young children, you can go more hours. Home is and family is the natural environment for a young child. I also like to see kids in preschool and kindergarten, and sometimes we see ABA providers suggesting that they stay in clinic ABA until they're 6 or 7. I'm not really a fan of that. I don't think there's any evidence that that is effective. So it just sort of depends. But the good news is that the high hours are often very difficult for families to manage. And it's just not necessary. And for our kids who are in school all day, 32 hours a week of school, then they come home if they're having home ABA or clinic ABA after school. I think we're causing mental fatigue in those kids. I think we need to be really, really careful. We are over-treating this population with behavioral treatments. And I believe in behavioral treatments. Don't get me wrong. I think ABA is fine. I don't think it's the only thing, but I do worry about over-treating.
I have a vignette that I think will speak to this. That is a recent situation that happened. I was consulting with an agency, one of our agencies that is a subcontractor with us, who was working with a 7-year-old autistic girl who has what we would describe as dangerous behavior that's going to lead to her being hurt or people in her environment being hurt. Probably not at this age, law enforcement involvement, but maybe as she gets older. So this girl is coming into a clinic multiple times per week, and this provider has recommended a 2-to-1 ratio, a 7-year-old who has severe, like an intellectual disability and autism spectrum disorder. So she's very impacted by her diagnoses. And they're having her come into a clinic multiple days per week. 2 adults are working with her at any given time. Now, I have an 8-year-old girl who is typically developing, who also has anxiety. And I can only begin to imagine how my typically developing 8-year-old would feel if 2 adults were trying to engage her in various activities. She would be very overwhelmed and she would be very scared. So this girls, they were having her in the clinic, increasing her clinic time. But as they were increasing her clinic time, her dangerous behaviors were increasing and increasing and increasing. Finally, to the point where she started engaging in fecal smearing. Fecal smearing was a very effective and adaptive way to deal with her stress, because as soon as she started fecal smearing, people got out of her way. They didn't want to be touched. And so I was like, you know what? I explained the anxiety component, the fact that she can't understand language. We're putting all these demands on her. And I just received an update last week from the provider that they have moved to an in-home parent-mediated intervention, and all of her behaviors are going down. And just demonstrating, like, we're equipping these providers are equipping the parents to deal with these things. I can only imagine the level of anxiety this little girl is experiencing on a daily basis. And the amount of improvement that has happened over a 2-month period. It's just remarkable. So a case vignette of a 40-hour-a-week program, high hours being truly ineffective for an individual.
And harmful, really harmful.
And harmful.
Yeah. I know we're out of time. Thank you so much. We enjoyed talking about this topic. So reach out to us, please. We have a lot of good information on our website, and we're happy to support in any way we can.
Thank you all for the great conversation. Thank you to our presenters for giving us such a straightforward and clear and informative presentation. But we are not always so interactive. So we're really happy to have people asking questions and sharing their thoughts and ideas, and lots of thank yous coming through in the chat. Next time, 2 weeks from today, we'll be talking about pediatric urology with Dr. Ronald Sutherland. So please join us for that, for those of you for whom that's relevant. And everybody have a wonderful day and happy Lay Day.
Thank you.
Thank you all.
Dr. Samelson and Dr. Sneed.